society, but in less hospitalized people. Still hospitalized people, but not so sick. According to, I met the authorities, the medical officer of the authorities yesterday, and according to him, it's improving steadily. But it is sometimes picking up because they do have a spread. There is no restrictions, no masks, no.
Yeah. So it's a bit of an experiment, huh? It's a bit of an experiment, right?
Yes. They just, took it away like this. It was very strange when you come off the airplane and it's all open. I should have taken a photo from yesterday when they sat outside, all the people in the restaurant full again.
Is it officially that a mask is not necessary over there?
Yeah. Yes.
Oh.
I think it's not mandatory, but you can use it. I think, isn't it?
No, I think it is a news for me that some country has now said that there is no use of any mask or so on, because to me in Pakistan, even people are not wearing all these masks, and I think that stands true for the Bangladesh or some other countries in the world. But as far as the health department is concerned, they are still asking for the wearing of the mask. That is still, I believe it is important indeed.
Hey guys, so I have to interrupt you over here. We are live on the session and we can take our 0 hours after this. So good morning, everyone. Welcome to 102nd session of CMMAO International Weekly Meeting. We have completed 100 and we are doing a lot of information exchange on this platform. Today we are again meeting up for an important topic. COVID era has not been over. And then we also want to discuss about how are the doctors doing their job on this era. So heart surgeries in the era of COVID is what we are discussing today. And we have a very important speaker, Dr. Sujoy Shad. He is a senior consultant cardiac surgeon and a director of cardiac transplant from Shri Gangaram Hospital. It's based out in Delhi. He has performed many life-saving operations on some of the most high-risk patients in his field. He is the only and also one of the cardiac surgeon to successfully perform heart transplant in a private hospital in North India. He completed both his MBBS and MS from AIIMS Delhi, one of the very prestigious hospital. He has completed FRSC CTH super specialty from UK and trained under some of the best minds in cardiac surgery. He is in some of the best cardiac centers in the world. As of today, he has done more than 20 years of experience in the cardiac surgery, patients with valve mechanism, and he has published many papers, annals of cardiac surgery. He's previously worked with Hereford Hospital, St. George's Hospital, and Queen Elizabeth Hospital from UK. Today, he's been practicing in Sir Gangaram Hospital. Sir, over to you.
Thank you very much, Saurabh. Good morning, everybody. Without wasting much time, I think I'll go ahead and start sharing the screen. But it was a sudden surprise when we got the news of COVID 2 years ago. And with the information that came in the very beginning, we all had no clue as to how we are supposed to deal with the evolving situation. The first thing that happened in our country, in Delhi, in India, was that we got a very harsh lockdown. We were slightly lucky compared to other countries because COVID first surfaced in Europe, almost following the same path as the Middle Ages plague, Black Death had surfaced. It went into Italy and all, and then came down to Iran and then moved around. But that gave us time for at least 2 months to figure out how we are supposed to behave. So the harsh lockdown in India provided us opportunity to get sorted out with masks and PPEs because they were considered the most important factor at that time. There was a shortage of sanitizers in the very beginning, the shortage of masks, the shortage of PPEs. And all this got figured out during the time of the initial harsh lockdown. And I think that was a very good thing. In addition to the development of PPEs, the hospitals were told to shut down operations. More or less, we came to a complete standstill at that time. Once again, that did not expose the hospital staff and the doctors to much of COVID. We did not have much of COVID anyway at that time. But because the information was lacking, we did not know how to behave, how to treat these patients. Things were very difficult. And there then started coming these papers which talked about myocardial injury in patients who are surviving from COVID. And ACE, angiotensin converting enzyme receptor mediated injury to the cardiac muscle. This whole thing started, and before we could get further, there was a panic in the world that even those people who are not suffering from apparent cardiac illness are suffering from myocardial damage in the form of fibrosis visible on MRI. Our bigger problem was respiratory. We did not face much cardiac issues at that time. And our cardiology work, it went down, and cardiac surgery work went down, partly deliberately, partly because people were locked up at their homes, and partly because I think at that time with a forcible rest and relaxation that the whole country had to go through, the stress factors which precipitate acute myocardial ischemia and infarction, they reduced. But this is again a theory that many of us have started believing in. People are having food at home, people are having rest and relaxation. Even though there is a stress of an ongoing pandemic, these factors became very important in our minds in reducing the number of people who were suffering myocardial infarctions at that time. We, in Delhi, we have two types of patients that come to our hospital. One are the local patients. So from our local geographical area, we get about 40% of our patients from the local geographical area and 60% from outside Delhi, from neighboring states and foreign countries. We did not have more than 10% admissions compared to our normal. Now that would suggest that the local population also had reduced amount of myocardial damage, acute coronary syndromes, and myocardial infarctions. So one thing was direct ACE-mediated cardiac myocyte damage, hypoxic injuries, thrombosis. And the hyperinflammatory state in the very beginning was followed by recovery in a majority of patients. But the lung damage at that time became more and more important in the initial phase. They were out from the American Association of Anesthesiology, and they suggested that we must wait. That became a very important event in our management of these patients.
I think we have lost the speaker because oh, he's back. So you need to unmute yourself. I think your connection is.
Connection became unstable a short while ago.
Yeah. Okay. Right.
So we had multiple issues going on along the cardiopulmonary axis. There was a lot of hypoxia, a lot of pulmonary infiltrates, effusions, and respiratory failure. There was a small amount of left ventricular dysfunction. There was a certain amount of stress-induced cardiomyopathy. Now, that stress-induced cardiomyopathy might have been as a result of completely failing lungs, which could not be recovered, revived, or settled with ventilation and and additional oxygen therapies. In the first phase, we did not go through much of ECMO because we were not fully prepared for it, and because there was a global supply chain issue. Newer machines could not be brought in. Existing machines could not be supported because we lost out even on our oxygenators, the ECMO oxygenators. There was a global shortage of ECMO oxygenators. We did not have much stock in India, and the countries which were suffering from major COVID damage in the beginning could not be supported from any other source because of lack of supply chain. Diffuse myocardial edema was visible on many MRIs, but once again, because in India we did not have a major problem with the first phase of COVID, we managed to escape this feat. As time passed, myocarditis became more and more visible. Myocarditis was visible as edema on T2-weighted scans and hyperemia on early GAD. And over a time, we also saw a lot of fibrosis developing on that. So we'll move. Then came what can we do with for surgery? There were patients who were coming in with acute coronary syndrome who needed angioplasties. The patients who could not be treated with angioplasty also needed consideration for cardiac surgery. And whenever we had a patient who was crashing, like an aortic dissection or critical left stent with multifocal disease, we ended up performing coronary bypass operations as well at that time. Our elective work in terms of valves, we stopped it completely and postponed it to the time after COVID. And basically that's the thing we've started doing almost now. The emergency cases that required surgery underwent surgery, but we suffered a lot of problems in those patients. And I think that is a very important topic for today. The most important problem that these patients suffer is persistent hypoxia after operation and persistent vasoplegic syndrome after operation. If you would give me a little, if you would be with me for a while, when we do coronary bypass surgeries in India, it's almost always an off-pump coronary surgery. And in that scenario, in off-pump coronary surgery, most of the patients, they require almost negligible amounts of vasopressors after surgery. But in COVID patients, we started seeing persistent requirement for vasoconstrictors and inotropes lasting as much as 5 days. In general, our normal patients that we operate, the patients without COVID, when we operate them, these are people who are out of bed the following day after surgery and they're ready to get home 5th day. Any patient who had suffered even mild COVID, we would have to give them inotropes, we would have to give them vasoconstrictors for as many as 5 days and in substantial doses. And that became a talking point amongst anesthetists and cardiac surgeons all over the country, that we are suffering this. Is this something which is expected? And over a period of time, as we gained experience, we would start suspecting patients who have not had clinical COVID if they required post-op vasopressors. So patients who underwent operations in that COVID positive patients who underwent CABGs, plus valve operations at some stage, these patients required a lot of aftercare in the intensive care. Interestingly, a few days ago, I was contacted by a very senior doctor from South America because they had suffered a sudden death in a patient who was expectedly doing well. And he was asking whether we had seen anything like this in post-COVID patients. We've seen a fair number of fatalities from patients who underwent a standard bypass operation for a standard coronary disease and underwent death. These patients required a phenomenal amount of inotropes and vasopressors, and excessive amount of vasopressors and inotropes would often lead to gut ischemia, etc. But overall, these bodies are inflamed. These bodies need time, and I think the initial dictum that we must wait 3 months for anybody with significant amount of inflammation during the COVID should be maintained. So emergency patients underwent surgeries, and we bore with that. Semi-elective patients were turned into elective. We tried to push their operations for a week, 2 weeks, or a month, if that was possible. There were some patients who required CABG, but because the ongoing COVID onslaught, you wanted the patients to move out of the hospital fast because there was not enough hospital beds, and you did not want to keep the patients occupied in the hospital. So some patients underwent stenting to bypass the bypass operation itself. And elective patients were postponed. We postponed these patients for as long as 6 months, 9 months, and basically we started operating on those patients now. It is important to understand the reason why we were postponing these patients. There are many centers in the West, especially France and US, where patients who underwent surgery during the course of COVID had a very high mortality. The average mortality ranged from 24 to 41%. So these are patients who were very high risk. Inflammatory process in the body had not ebbed, and we had to give another inflammatory insult in the form of an operation at that time. So very important that we tried to postpone whoever that could be postponed at that time. We did a lot of things that everybody else was doing. We wanted the patients to be PCR negative. We wanted patients to have high levels of antibodies. We were looking at cycle thresholds. And finally, we started looking at CRP. So patients whose CRP levels were about 5 times normal, we were prepared to operate. But patients whose CRP levels were very high, we would try to postpone them and get the physicians and cardiologists involved in some manner so that we could delay their operations. Single center cluster, many patients operate at the same period. The outcome, what happened in the previous era and what happened in the next. So mostly from being a dominant, we went to a dominant aortic valve, which was into the as I had was the most less.
You're breaking up. Your network is still, again, I think, unstable. It's very hard time to hear you out now.
I'm sorry, but you see the many post-operative complications that we suffered. Standard ventilator assistance time increased. The length of stay in ICU is increased. The mortality is increased. Infections, pulmonary infections increased. Abdominal issues increased, and we ultimately ended up having a lot of mortality. At 1 year post-COVID, this is the cardiovascular outcomes we are looking at. Almost every problem, whether the patient is non-hospitalized, hospitalized, or in the ICU, is worse. But patients who did not require hospitalization, they tend to do much better than those patients who are hospitalized or ventilated. So cardiac disorders like heart failure, ischemic cardiomyopathy, cardiac arrest, everything that can go wrong in these patients, that went wrong. We sidestepped the alpha wave chiefly because of the harsh lockdown, but delta wave hit us very, very hard. And majority of the ECMO that took place in India at that time, it was during the delta phase. Some centers went on to recommend early ECMO. So patients who went from high flow nasal oxygen to ventilator were immediately placed on ECMO. There were some patients who moved from high flow nasal oxygen straight onto ECMO without going through the ventilator phase. But the results all along were terrible. They were terrible results, and if I may say, in India, their salvage might have been in the order of 10 to 15% of patients who underwent ECMO. Remember also that was the time we had no beds. That was the time when we had no oxygen. That was the time we did not have ICU beds. That was the time also when a lot of hospital staff had suffered COVID during the Delta. Most centers abroad have reported a mortality around 60%. So they had almost half and half improvement. But dare I say that in India at that time, probably because our patients were much worse than what was going on in the rest of the world, we had a very, very high mortality even on ECMO. And many, many centers stopped doing ECMOs for Delta wave, having seen the results of the outcomes of their own and the neighbors' ECMO results. Thank you very much. Hello.
Yeah.
Thank you all very much for a patient listening. There was not much that from the cardiac surgery point of view, which was important, other than that we need to look at the CRPs. With the Omicron wave, we have become a little more comfortable because we realize that the inflammatory process in the body is not very harsh. And in these patients, if the CRPs are trending lower, we tend to go ahead and operate.
Thank you, Dr. Sujoy, for the wonderful presentation. Now we are opening the forum for the question answers. Let me welcome Dr. Chong, who's the chair for CMMAO, Dr. Heidi Sintman, she's a president for WMA. We have about 19 countries over here. And let's open the question answers. Yes, Ravi. Ravi.
Yes. Thank you very much for a wonderful
In fact, this is
hello.
I just want to make a tiny request that there will be a lot of people with a lot of experience with COVID on the panel today, and I would welcome comments and advice from everybody who is available here. So instead of making a kind of one-way traffic, I'd be really grateful if everybody contribute here, please. Thank you.
Not much money.
Hello.
Yes, go ahead.
Yes. My question is this. What about this incidences of post-vaccination endocarditis and, a lot of cardiac complications due to the vaccination? Doctor? Can you give us some highlight on that thing?
In our hospital, we have really not seen much of a problem with COVID vaccination leading to myocarditis. It is possible that the myocarditis or let's say cardiac failure, which many patients abroad have gone through, might have been treated as pulmonary pathology, because the heart failure, pulmonary pathologies, they mix in. But I do remember there were 5 patients that were admitted with congestive heart failure immediately in the aftermath of vaccination, but we could not prove a link between the vaccination and the myocarditis or cardiac dysfunction. Many of these patients would generally have existing heart failure, and they become hypoxic, and that combination becomes very bad for the cardiopulmonary axis. And secondly, endocarditis. We suffered endocarditis as a result of the fungal infection. There are a lot of fungus in the delta wave, and the ENT fungus. I'm forgetting. And during that time, we had 2 patients who came in with fungal endocarditis that we had to treat emergently.
Thank you, Doctor.
Sujay, can I just have a question?
Yeah, go ahead, Dr. Jamal.
Thank you. Thank you very much, Dr. Sujay. Actually, it's nice presentation. Actually, this has attracted much because we are just dealing mostly with the pulmonary complications, pulmonary problems actually during the COVID-19. And this is actually, I have seen even the highly cared patient, not one or more than one, or maybe in my knowledge, I have seen this. He was supposed to be discharged the next morning, and he died that night because everything is okay, but died at night. So, what we heard that he had mitral infarction and died, severe mitral infarction, and not one case. And even the post-COVID patient also, the patient was suffering highly, definitely long for many days, and he was in the hospital. Went to the house, and after that again he got a problem, and he entered into the hospital and died. So this thing actually, I think, because there is abundance of AC receptor in the heart muscle, cardiac muscle. So maybe the heart was, we just not cared much for the heart during that pulmonary problem and this. But I feel like that. Do you agree with that?
I totally agree with that. We actually had some extremely high profile
I think connection is weak.
Dr. Sujoy, we've again lost your connection. Dr. Sujoy, why don't you close your camera? I believe the connection, the voice will be better.
Okay, let's do that. Is that better, Saurav? Is that better, Saurav?
Yeah.
Is it okay?
Okay. Yeah, I think that's a very important observation. We had many patients, high-profile people who died during the course of COVID suddenly, and also there were people who went home and died the next day. I suspect that these patients might have had pulmonary emboli as a starting complication, because there's a lot of thromboembolism that went on during that era. A lot of thromboembolism, and patients were developing stress cardiomyopathy. Patients were developing heart failure, and the combination of a small pulmonary embolus in a patient who has suffered severe pulmonary complications and has heart failure probably did the entire damage.
Thank you.
Dr. Angelico?
Morning, and thank you so much for a very interesting discussion. I just would like to know, going forward, is there any way that if a next variant would be just as much giving a lot of inflammation, especially cardiovascular inflammation, is there a way that we at primary healthcare level already can start to identify high-risk patients and try to treat them when they come in with their normal COVID symptoms, as to prevent them going into this phase? Is there any way I'm not sure, except the normal things, but as you have said and indicated, it was very bad during Delta. And I'm not sure whether we do have enough tools to prevent. Do you maybe perhaps can help here?
Dr. Angelique, I have been watching your videos and your commentary on Delta and on Omicron. And actually, I think you are the person who's been in the thick of things much more than the rest of the people have been. And I think the world did follow your advice during the Omicron. And I'm grateful that you're asking me a question, but actually, if you ask a question, that means there is no answer to it.
Thank you so much. Thank you.
Thank you, ma'am. Thank you.
Can I make a comment?
Yes, please.
I think I was quite taken aback when I saw the Veterans Administration study of 150,000 veterans who had COVID for a year, and some of the data that came out there were shocking. For example, in that 1 year, stroke was 52% more than the controls, and the pulmonary embolism was 300% more than controls. And deep vein thrombosis was 200% more than controls, and myocarditis was 500% more than controls, and MI was like 63% more than controls. And in these were those who were not hospitalized, but those who were hospitalized or were in ICU, the MI rate was something like 400 and 900% respectively. Perhaps Dr. Sajat, Dr. Shad would like to make some comments about that Veterans Administration study.
See, it ultimately boils down that there is an inflammation, and many patients are presently suffering from long COVID, or for the lack of any sensible way to describe it, we got to call it long COVID. Many patients, and many patients have presentation with vasomotor issues. Like you have patients whose sympathetic and parasympathetic systems seem to be malfunctioning. We have enormous amount of thrombosis, vascular inflammation that has gone on, and it is not subsiding as long as 2 years after the patient's first episode of COVID. So we are still in the middle of this, and I think we can't allow our guards to come down. We really need the whole population to be vaccinated, and there is no shortcut getting out of here. The vaccinations will protect patients in the future, and if we get yet another variant, it might be that the vaccination can help us there. And then we have the other side, that vaccination itself is causing a certain amount of inflammation, and you can't take it very lightly. Vascular inflammation, vasomotor issues, myocardial damage, pulmonary damage, all these things are matching up, mixing up, and causing trouble for us. And I don't think we are out of the woods yet.
Dr. Shad, you were talking about the POTS, is that right? Postural orthostatic tachycardia syndrome?
That's once again it. Yes, absolutely. Thank you.
Yeah. Monica, do you have any thoughts about that Veterans Administration study from the US? It was quite frightening to see the data.
I agree with you. First of all, Dr. Shah, thank you so much for a fantastic presentation. It was nice to hear your perspective, especially being through the Delta wave and seeing the myocardial burden as a result of not only the COVID infection, the pulmonary emboli, and the fungal infections that were happening. I'm very concerned about the long-term effects of prior COVID vaccination, COVID infection, whether or not it was requiring hospitalization or non-hospitalization. And even extending beyond the cardiovascular implications is also the neurological implications. the dementia. And that's where the POTS comes in as well, because I think that also has a neurological basis as well. So I don't think we're out of the woods. And I think that the post-COVID sequelae that we are going to see, and that'll be the new pandemic for us as we come out of the viral pandemic, is going to give us more information. I don't think we've completely quantified the burden yet. I don't think we completely understand.
I totally agree with you, but we need to keep our eyes and ears open. We need to be interacting more and more with colleagues around the world who've got more and more experience and information.
Okay. One question in terms of the general public. We have seen this pandemic, the side of doctors. What happens, in terms of the patients, what all surgeries they can delay, because, in this pandemic, we have seen there were no beds. Mostly they were COVID. There was a fear of, even if you go for a surgery, you can get COVID affected. So even if you're sitting at home, and a lot of people have been less affected because obviously the lifestyle had changed. There was a different, I think people were taking medications, the lifestyle and the eating habits, the pollution, everything reduces the, the whatever was going on. So what is your advice if I don't want, but if the world faces another pandemic, what is your advice for the general public in terms of what surgeries they can, delay it, what surgeries they want to, they cannot delay it?
Right. No, this is really a complicated question, and if I may say that emergency surgeries will need to be carried out. So a patient who presents with an aortic dissection will need to go through an operation. A patient who's getting symptoms which are worsening, their patient will require an operation regardless of what is the COVID situation in the country. But elective work, where we say that the patient can have an operation in the next 2 weeks, we could comfortably postpone that to 2 months, and if the patient stays stable, maybe a further 2 months. So issues, acute cholecystitis requires
I think we have lost him again.
Yeah.
Dr. Sujoy, we cannot hear you.
have oxygen supply to operate the ventilators. We've been through hell. We've been through hell during Delta, and I hope we don't need to see another one of these. And hopefully, with the vaccination catching up speed all around the world, the pandemic would finally truly be over. Thank you.
Okay, great. So, Dr. Chong,
Dr. Pillai, this venous thrombotic episodes definitely has been on the higher side with COVID. Normally, in a hospitalized patient, it used to be 12% or so. Here, it has been 27 or more. And even with the cardiac patients, it could be still more. And what is the regime of treatment? Whether you use unfractionated heparin or fractionated heparin, and how do you monitor it? Do you use anti-10A levels or APTT?
Dr. Sujoy, you want to answer that?
Sorry, I didn't get that question.
No, the venous thrombotic episodes have been higher with COVID patients, particularly those with the cardiac symptomatology. And whether you prefer to use unfractionated heparin or ultra-fractionated heparin, and how you monitor that, whether you use APTT to monitor it or anti-10A levels.
We're actually happy with the new rules, and we do not monitor it. These patients are kept in about 10 days after they're discharged from hospital or no, and thereafter clinic was defined they continue on anticoagulants.
How long you continue the anticoagulant? 3 months or more or whatever? Or is it based on FETT?
That's a very difficult question, and it has been individualized. And there's a lot of patients who continue it for 3 months, and a fair number, if we do not have dogmatic proof of venous thrombosis, we stop it in 10 days' time. But almost every patient who was discharged from hospital got no evidence.
Thank you. Our experience has been that
Thank you.
high flow oxygen, those who require only high flow oxygen, the survival rate has been extremely good. Even non-invasive ventilation, the results are not bad. But if it is a IPP where regular ventilation, if you go, then the mortality has been very, very high. And I suppose you may be having the same experience.
I think we have a connection issue.
It's the same experience if patients with high flow oxygen.
Okay, Dr. Chong, so we have Dr. Monica with few slides to present, and then we have Dr. Elvin who can present on the Hong Kong. If that's okay, we can go with Dr. Monica to present first few slides, and then Dr. Elvin can cover us with the Hong Kong situation. Is that okay? Okay.
Sounds good, Sarat.
So we invite Dr. Monica for her few important knowledge sharing with us. Go ahead.
So I just wanted to give a moment in time update. We've crossed 6 million deaths globally, at least those that have been counted. We are, the reason I post this is because as we are trying to find normalcy now, we can't forget how we've gotten to this point. We are going to continue to see a long tail to this pandemic, whether or not it's a thin tail or still a fat and then thin and fat and thin is yet to be seen. But I do agree with the comments made earlier that we cannot let our guard be down. If you look at the US surveillance, sewer surveillance, looking at the presence of the virus in the sewage, we are seeing, at least in the first 2 weeks of March, that there was an increase in the amount of virus shedding. More than a third of the places that were monitoring the sewage showed rising COVID-19 trends. And I live in Wisconsin, which is, if you can see my cursor, is right in this area. And right where this really dark orange area is where I am. And where I am is where masks are not mandatory. It's completely voluntary. My kids are not wearing masks in school anymore. And this is concerning that, that we are still seeing this surveillance data. And as mentioned earlier, we still need to continue to reinforce the benefit of immunizations. This was a tweet that was posted by the CDC regarding the mRNA vaccines, showing that they help protect against the most serious COVID-19 outcomes. And I will say that whatever vaccine is available is what I would recommend to the population. And this is just a reference to what is available here. And so these are the advertising efforts to get vaccinated, as well as to get booster. So here it's saying adults who received 3 doses of a COVID-19 vaccine were 94% less likely to be put on a ventilator or die from COVID-19 compared with adults who are not vaccinated. It is nice to see this messaging out to the public. What have we seen this week? On the 15th of March, Pfizer and BioNTech requested authorization from the FDA for second booster doses. So this would be a 4th dose. Moderna made a similar request yesterday. Requests were based in part on data from Israel after the emergence of the Omicron variant that showed a second booster dose lowers the rate of infection and severe illness. I made a reference to not only the cardiovascular complications and monitoring patients after COVID vaccination, but also related to neurological. And this is just one study that was published in JAMA on the 8th, and it was looking at cognitive impairment in older COVID patients. It showed that cognitive impairment was more common in those patients who were 60 and older, particularly those with severe illness who were released from hospitals in Wuhan, China, than among their uninfected peers. So I think the story is continuously being written here in terms of what we are going to continue to see in terms of the morbidity associated with infection. What about kids? What do we know about children? So children have low levels of COVID antibodies after infection. And this could partly be because they're able to clear the virus from their bodies much quicker than adults. We know that children and adults have similar symptoms and levels of virus with the infection. But because of this initial and robust response to COVID-19, they clear the infection and they don't make as many antibodies. And why is this important? Antibodies are likely to be important for guarding against reinfection and how well they are protected in the future against this infection. And this was published in Nature. What else are we worried about with children? And that is looking at the effect of school closures and the so-called loss of and the loss of a generation. We know that 1.6 billion children globally, or more than 90% of all school students, have been affected by pandemic school closures. Robert Jenkins from the UN said, "We're running the risk of a lost generation. It's a now or never moment to turn things around. Without urgent action, many countries could end up without the skilled workers they need for their future development." Concerned about the risk of social instability in countries where a large number of youths are left without skills, job, or hope. So that particular statement shows us that we are going to continue to feel the impact much, much longer. And we also know that children in low and middle income nations have been disproportionately affected as their schools tended to shut for longer and they were less able to access remote learning. And that's it for my slides today. Thank you.
Thank you. Do we have quick questions for Dr. Monica? Otherwise, we can invite Dr. Alvin.
Saurabh, I have a question actually.
Go ahead,
Dr. Monica, you are showing that having the vaccination, you are getting that 94% less likely to go to ventilator or death. So is there any effect of the Paxlovid or antiviral also added to that effect, or?
No, this is just vaccination only. This was just vaccination only.
But already the people are taking the antiviral also, Paxlovid or molnupiravir.
That's so now. This is data that was older. This is data that's older. So the antivirals is more recent.
I think the Paxlovid will give more effect, additive effect, because it is more than 89% effective against the virus. So
yeah, it'll be interesting to see. That's a great point. It would be interesting to see what the role of antiviral therapies in addition to vaccination and also prior infection. So if you consider prior infection like a dose of vaccination, that's also a little bit different. But if you're just looking at vaccination alone and looking at all data, then that is what it's showing.
This is only in terms of the Pfizer and mRNA?
These are the mRNA. So it could be Moderna or it could be the Pfizer BioNTech.
Even in India,
Monica, one question here.
Indian Council of Medical Research has done a study and it has shown that those who are vaccinated double dose. They are protected 98%. That is definitely less, 98% less in those who are vaccinated. But our vaccine, Covaxin and Covishield, AstraZeneca and Covaxin, even with that, this much of protection definitely is there for vaccinated people.
Thank you for sharing.
Dr. Monica, one question. Here in Malaysia, there's a lot of hesitancy for vaccination of children between 5 and 12. What is your experience in this, please?
Yes, there is a lot of hesitation. I actually, in my clinical experience, so based on the demographic or the patients that come to see me, I see two populations: those who stood in line right at the beginning to get their children vaccinated. And then I have the other population that has absolutely no interest in even talking about it. Forget about getting the vaccine for the child. I feel that it's going to take some time to understand that population in terms of risk, because we did see that with the Omicron phase that there were more children who were getting infected and who were being hospitalized. But by and large, we haven't seen the burden of the morbidity and mortality in that age group as we have seen in the older adults. And if their parents are vaccinated and you have a ring of immunity around these children, especially for children who don't even have access to immunization, I think that's where we can kind of also have conversations, is making sure that their parents and grandparents are vaccinated.
Okay, thank you, Dr. Monica.
So Rob, shall we get Alvin to tell us about what's happening in Hong Kong? Alvin?
What kind of story?
All right. Hello, everybody. Can you hear me? Yeah, this is Alvin speaking from Hong Kong. Hello, can you hear me? Yeah.
Yes. Yes.
Yes.
Yes.
Absolutely loud and clear without mask to wear.
Risky.
Thank you very much for the lecture, Dr. I was late just now, so I hope that later on I could also have the slideshow available in our WhatsApp group, and also in the communication in the e-communication. So in Hong Kong, of course, the situation is not yet good, but then we are fighting hard. So now we had already had 91.5% of our population being vaccinated with the first dose, and then almost 82% of our population vaccinated with the second dose. Well, but then of course it's not good enough, because that means we still have 19% of our population not yet vaccinated with the second dose, and that is they are not protected well enough. And that is quite a lot. That's why even we have such a high coverage rate, there is still a high infection rate and mortality rate in Hong Kong right now, because especially for the over 80 years old age group, is only still about half of the population in the old age home, or for those over 80 being vaccinated. That is, they are not really protected. And that's where the mortality and the ICU cases come from. And that is not a small figure, of course. We still have about 200 deaths a day, and most of them elderly and immunocompromised. Well, that is, we have now 5,400 deaths already, out of 1 million population being infected altogether. So the mortality rate is then, of course, 0.5%. is not good. And basically, it's all within these 2 months of the fifth wave of the Omicron. So, in fact, our weak points first is the elderly over the 80 years of age, and even in the over 70 is less than 80% being vaccinated. But then the other weak point, of course, is the young children. For our young children, that is 3 to 11 years age group, we already have 56% of these children vaccinated with the first dose only. Yet, because this exercise began only after the 15th of February, so that means we only have 8% of our 3 to 11 age group with a second dose. So that is 92% of our 3 to 11-year-old age group is not really protected yet, all right? So we have to work hard, and we will drive up this vaccination coverage by having locum and voluntary teams of our doctors to go to the old age homes to have the vaccination for these elderlies. And it would be an opt-out, like an opt-out exercise. That is, unless there is a written objection from the patient or from the relatives, then we will carry out the vaccination for those who don't object. So in the past, many relatives, in fact, had sort of, quote unquote, protect their elderlies from vaccinations, which could give rise to side effects when they heard all about the, say, initial mortality after the Norwegian, studies that many of their elderlies had died after the initial vaccination at that time, 1 year ago. So many Hong Kong people were unfortunately impressed by such, a perception at that time. And even after there is clarification that those mortalities is not really related to the vaccine per se, then people could not really change their mind at that time. And so until February this year, many of those elderlies in the old age homes could not have the vaccination because many of these relatives of the elderlies in the old age homes still opposed to the vaccination for their parents, elderly parents. And also because many doctors, unfortunately, I would say that, say last year, still had a little bit of reservation about vaccination of these elderlies with multiple chronic diseases. And they are worried that giving the vaccination could worsen their conditions. And so they have to bear the responsibility and the liability after they sign the agreement, the consent that these elderlies would have the vaccination. So many of those visiting doctors going to the old age home hesitate to approve vaccinations to those elderly people bedridden or with some chronic diseases. And that's why now we have to overcome all these hesitations. And so now we will just hope to give vaccinations to the elderlies as many as possible, as soon as possible. And whatever the outcome is, we hope that 95% of our population would be vaccinated within, say, early April, hopefully. And then especially for these elderlies in the old age home. In fact, it's only about 50,000, just 50,000. But, well, of course, our mortality now picture is only 5,400 deaths. But if there are still 50,000 elderly over 70 or 80 not vaccinated, there could be many more coming. So we must hurry up to vaccinate these elderly. All right. So for the in fact, for the confirmed cases in the recent Omicron epidemic, I think, in fact, there's a pandemic. Many of them are asymptomatic, but we don't have the hospital facilities to entertain all, and not even the isolation facilities to entertain all, because every day there could be 30,000 positive cases. For the recent 2 days, it seemed to have dropped to about 2,000 cases a day. But then there are some hidden cases, because some of the citizens still would not opt to reveal their positive status to the government. That is because they don't want to go to the they think that the isolation facilities are not good enough. There's no privacy. The food is not good enough. They could not meet their family members, etc. So they rather will isolate themselves at home. You know, like a gentleman's agreement. They would think that they could stay at home and not infect other people. But there is, of course, one of the problems that we face in our sentinel surveillance, and also for the implementation of the mandatory testing. So that is, we could not really enforce this. We don't have a mandatory, rule that anyone having the RAT positive testing by himself or herself must report to the authority. So many people will keep these as their own secrets, but then in fact they could infect their family members, of course. They could also infect their neighbors, because we found that now it's confirmed that there is airborne infection. It's not just a droplet infection. So in fact, because it's so contagious, there is a very high possibility of spreading through the sewage system, drainage system of the buildings. They could spread through the exhaust fan, drawing the air out of an infected household. The virus particle could be exhausted out to the light well and the common space in the building. And so we are now testing the sewage water drained from the tubes of the pipes from the building. And so when the department found that the water was positive with the virus, we will have to lock down that building or even that estate to test everybody within the building or within that estate, so that we could find out those hidden cases in those buildings or those estates. And every day there are many buildings being tested with people with the residents in the buildings being tested, and every day there could be hundreds of residents tested from these buildings with water positive with the virus. So that is our situation, and we have now the Paxlovid and also the sorry, the Molnupiravir available in the public hospitals and the designated coronavirus, COVID COVID-19 clinics. That is only available in the public hospitals and the designated public clinics, not available in the private sector yet. So in a way, the role of the private doctors now mainly would be to see the non-infected cases and to give vaccinations. We have been participating in in the pandemic in these two big roles. For the management of the infected people, they will be concentrated in the public sector, in the public hospitals and the designated public clinics for the COVID-19. And that's why the colleagues of, half of our colleagues in Hong Kong are working in the public sector. Half of us are working in the private. We are sorry to say that then the private hospital doctors, private clinics doctors, we want to help, but we don't have the access to those medicine, and we don't have the isolation facilities, or the even the PPE is not a complete one for many of our GPs. So our public colleagues had been exhausted, really exhausted, and many of them get infected. Perhaps only 2/3 of the workforce in the public hospitals could be functioning because many of them are infected or their household members were infected, and so they are close contact. And so it's quite difficult for us in this aspect. But I have to give salute to our public colleagues. They are working really hard, and no one is evading this crisis. And I have to give my thanks to them. So that's how our our situation in Hong Kong goes. I hope, well, with God's grace, we can go out of this crisis as soon as possible. Thank you.
Thank you, Alvin. It's really sorry to hear about what's happening over there, and our thoughts and prayers are with the Hong Kong people and with you. Hey, I didn't catch that part about the homes and the doctors not giving vaccination to the elderly. I didn't catch that part. What you said? What the reason was?
Thank you. So, in fact, they need to have a consent form for the elderly in the old age homes to receive the vaccines. So the family members of these elderly will have to sign the consent form. If they don't consent, then the elderly would not be able to have the vaccination. Now, of course, many of these elderly might have the mental state not capable of making a sensible decision. So they need the family members. But we are talking even about those sensible, elderly that could sign their own consent form. They would not have the vaccines if the family members object, because that would be a liability. The authorities and the old age homes officials, they could not bear the responsibility. If anything happened, the family members could sue anybody. So, and that's why also the doctors, they are visiting the old age homes perhaps twice a week or 3 times a week. They just see every elderly perhaps, then they have to sign a form. I mean, they have to give the vaccine to the elderly residents in the old age homes. So if he thinks that this elderly is eligible for the vaccination, having good health, good cardiovascular function, having no stroke and no risk of stroke after the vaccination, because in the first year of the vaccination, most of the media had really exaggerated the associated with, I mean, the elderly would die, of course, anyhow. And so, say, any elderly who had received a vaccine had died 3 weeks afterwards, the news will report it every time. So people were just impressed and had that perception that people would die after vaccination. So I think it's a misperception. But anyhow, the media had created such a perception. And the government at that time was slow and sluggish to explain, slow and sluggish to clarify, and slow and sluggish to give the scientific picture, to, overcome the fears created by the media at that time. So many of those relatives would hesitate. And then even the doctors, well, because the vaccine is so new, especially for the BioNTech, so many doctors themselves would not overcome their, peace of mind that this vaccine, would it be possible that could give rise to those things like, say, the blood clots, like the pulmonary embolism, like the stroke, like a heart attack, anything, all right? Because there are cases of facial palsy. There were cases of, say, Guillain-Barré disease, and there could be cases of people would suspect that some, adverse events were really, truly, consequence of the vaccination. They could not be 100% sure. So that's why they would protect the elderly or protect themselves, the liability of the doctors giving the vaccination to the elderly. They would not give the vaccines to those, quote unquote, susceptible, vulnerable elderly. And that's how it came to the reality that up till January this year, only less than 20% of the elderly over the age of 80s would be unvaccinated yet. Welcoming Omicron with only 20% vaccination coverage in this extreme old age group and for those in the elderly homes. Because even they are 70 or even they are only 65, when they are infected with the COVID-19, they are still vulnerable if they are unvaccinated. Even the younger ones with uncontrolled diabetes or hypertension, they could be vulnerable if they are unvaccinated. So I'm so sorry that because Hong Kong has a freedom of speech, freedom of press, that's the results in a way. So that's why in mainland China is a different story, because in mainland China people are less doubtful, perhaps. No, I'm sorry to say it's not, because even in April last year, there's a survey in mainland China in Zhejiang, is carried out by the People's Liberation Army, the Scientific Institute. They had surveyed people in China in April last year that only 28% of the people would agree to have the vaccination for COVID-19 at that time. You understand? So even the Chinese people at that time had such worries. And mind you, China had never carried out any mandatory vaccination in mainland or in Hong Kong. They are also having voluntary vaccination. But because their implementation of the social structure administration, their administration is a district-wise authority, have been very infiltrating. It's very good. So they could carry out the vaccination very efficiently, voluntarily, within half a year, going up to 80% or above. And every age group will be the same, just like Singapore. So my salute to Singapore. You also have all the voluntary vaccination, and very fast would be 88%. And I think one of the difference is the promptness the promptness of the health authority and the administration in Singapore to defeat those KOL spreading rumors, defeat the media spreading unfounded, rumors. And that is very important. The clarification is too slow from the authority in Hong Kong, I would think. Yeah. But now we are catching up. We are catching up. So we are hopeful that the vaccination coverage for the elderly age group and for the old age home would be up to 90% in mid-April, I think, at least. Thank you very much for your question.
Thank you, Alvin. In Singapore, we also need consent from the patient's family in the elderly homes. But fortunately, we've been able to achieve very high numbers. Although at one time, going into the Delta wave, we had about 60,000 elderly that were not vaccinated. But they were not in homes. They were not in elderly homes. They were at home in their own house. But even then, I think there was a huge effort to push the 50 to 60,000 elderly to be vaccinated. Huge push,
Yeah. So I always I always share those explanations from your authorities, the health ministry, from the foreign affairs ministry, etc., etc. Very good, but they are all in English, of course. They're only very, very few in Chinese. But in Hong Kong, most of the elderlies or the family members, they would, just have the Chinese clips.
Dr. Alvin.
We'll have to translate them.
Dr. Alvin, does antiviral is having any antiviral using? You're using antiviral, Paxlovid and others?
Yes, yes.
Patients? Because the number of deaths are so high. I'm telling you, what about the antiviral drug?
We have been using the Paxlovid and Molnupiravir since the early March.
Okay.
But it's only used in the public sector. It's only used in the public hospitals. But unfortunately, from the middle of February, our public hospitals were overwhelmed because we only have about 30,000 beds in the public hospitals altogether. Only 30,000 beds in the public hospitals. Then when there were more than 50,000 confirmed cases a day, we just could not cope it. 50,000 confirmed cases, although most of them are mild or asymptomatic, but people had, just, I think, hysteria. As soon as they found that they were positive, they just hysterical. They are so worried. They are worried about the Delta, how serious it is for the Delta, and for the initial primary one in Wuhan. So how serious it is. And then they would imagine that I could die, I could have very serious consequences, I would be left half dead. So I must go to the hospital. I must go to the A&E. So that's how it overwhelmed the public system, because all along our public hospital have been working very well. And yet, because Hong Kong is a very unique place, that we have half of our doctors working in the public hospitals. And half of our doctors work in the private sector. And that is our primary care have been contributed from the care from the private GPs, more than from the public hospital, in fact. And for the private hospitals, we own 5,000 beds. Altogether, 5,000 beds in the private hospitals. And just like you remember MERS a few years ago, 10 years ago, South Korea has suffered so much in the sudden epidemic of the MERS at that time. The private hospitals were overwhelmed at that time because which in the private hospital, there's just not enough isolation facilities. The isolation equipments were just not enough. The PPE for all the workforce is not just enough. So so the private hospital could not help, and the administrations would, with the policy, would be to have the care of COVID-19 patients all in the public hospitals. So for the past 2 years, so far so good, because only very, very few patients a day. But today is really different. 50,000 cases a day. Even today is 20,000 cases a day. If people would rush to the hospital, the public clinics, we just cannot deal with it. So that's why we take some time. We have to take some time to convince the public that please don't rush to the hospitals. Don't rush to the A&E. Don't rush to the public clinic. Don't even rush to the private clinics. Stay at home. We have the home isolation. But that's not the way out, because when you stay at home, you will infect your family members. You will infect your neighbors. So that in a way seem to have redemption for our hospital system. But it really exaggerated the pandemic, the crisis, because many family members are then infected by the index cases. Many residents in the same buildings were infected by the index cases living in that building. So I think it's difficult to solve these problems. Even with the antivirals available in the public hospital since the end of February, still it cannot solve the problem of the public hospitals being overwhelmed. So many people could not be admitted into hospital. That's why you could see the photos in the media that many people just have to sleep in the corridor, in the space outside the hospital, and died even there. They could not be admitted into the hospital at all because the hospitals were overwhelmed. Yeah, thank you very much for your question.
Saurabh, have we reached end of time yet?
We can. So I think we have covered. If Dr. Heidi wants like to speak something, otherwise we can end the session.
Yes, please.
Hello there.
Thank you very much for your concern about Hong Kong. Thank you.
Thank you.
Hello, Madam President.
Hello. Thank you. Thank you so much for the update from Hong Kong, and that you ran through the happenings. We have been following the pictures as well as that you described as well. Thank you so much for this session today, this Saturday. We've heard quite a few things from post-COVID to the spread, and also a short one of the spread in Denmark. I read the article here during the session. Very interesting. We can conclude that this is not over. We do have a high spread of Omicron, and we also have a rising problem with post-COVID. Fatigue is a big problem. Here in Sweden, we only have 10 million inhabitants, but we have 30,000 diagnosed post-COVID patients. That's quite a high number. Many were infected or got sick just in the first wave, but also now during Omicron. So this is not over, and it's going to be the theme for the coming year, I would say, and maybe years. I myself, I belong to the ECMO unit, so it was interesting to hear the talk from the start of the cardiac surgery and also the experiences from patients being on ECMO. We currently have one patient here on ECMO. So altogether, this was a variety of different topics, but this virus is affecting many parts of the organ systems, and not at least the neurologic system. So, well, I can only thank you for contributing.
Thank you. And I apologize on the behalf of speaker. I think he was traveling and he was kind enough to accept the invite. He was traveling from US, so the network was a little bad, but yeah, we got a lot of information out of him. So Dr. Chong, would you like to end the session?
Thank you, Madam President, and thanks for Monica for that update, and Dr. Shad, although he's not around, thank you very much for the very nice presentation, and thanks, Alvin, for the latest update on Hong Kong. I mean, our hearts and our thoughts and prayers are with you and your colleagues in Hong Kong, and with the people of Hong Kong. Especially here in Singapore, we always feel a kindred relationship to Hong Kong. So it's with huge sadness that we are looking at this situation unfold. I hope the worst is behind you or behind us. And without much ado, thank you everyone for attending today's session, and I look forward to seeing all of you next week on Saturday as per normal. Thank you all.
Thank you everyone for joining.
Thank you. Bye-bye.